Good afternoon, everybody. Hi, hope you're able to join us. Thank you very much to those that have. I'm Max Pardo-Rokes, and I'm going to be talking today about beyond your clinical systems, the critical data points that your practice is missing. I have a short presentation I'm going to go through to take you through today, talking about a variety of different areas that we found practice data that you won't typically have, and the impact that data might be having for you in your practice. So I'm going to share that presentation now. The presentation today is going to last about 30 minutes or so. If you do have questions, please pop them in the chat. I won't be able to see them as we go through, but I will come to them at the end. And if we don't have questions, I'll share some contact details with you at the end in case anything occurs to you later. So let's start. We're talking today about beyond your clinical systems, the critical data points your practice is missing. I've got 5 different examples today. There will be more. These 5 are quite high impact, quite interesting for practices, and I'll take you through a little bit more detail about why that is. So let's start with a bit of an introduction for myself. I'm Max Pardo-Rokes. I've been working in general practice improvement now for more than 12 years, supporting improvement through both NHS England's General Practice Improvement Programme, their Practice Level Support Programme, and various other practice-based improvement activities that have taken place over that time. I work for an organisation called Develop Consulting, and we've worked with about 1,500 plus practices over the last 5 years across the country, lots of different types of organisations, the very largest practices, the very smallest, rural, urban, and everything in between. Those that have been really good, those that are really struggling, sort of really work with a massive variety. And one of the things that I've been doing particularly is involved in the development of those programs, the improvement programs that we're talking about delivering here. But we've also seen where those improvement programs don't always fit the mark for a practice. And that's often because we're trying to make improvements based on practice data. Typically, practices take that data from the clinical system, and it's not always perfect. I'm going to share some information about that in a minute. So the data challenge for practices, your practice, assuming you're joining us from a practice, but across the country, practices hold all kinds of data and they collect all kinds of data every single day. Things like patient appointments, your incoming call data, particularly now that we've moved to cloud-based telephony services, patient prescription data, staffing rotas, there are loads. But does it really come together in a meaningful way for a practice whereby you look at that data, you make a decision on it, and then you're happy with the decision that you make and it works out how you expect it to? Often not the case. There are lots and lots of providers out there that will glean insights from your clinical systems. Typically, we find that they don't always ring true. And we think there's 2 key reasons for that. The first is practices don't really trust clinical system data. I think one of the best examples we've had of that in recent years was GPAD. Clinical system data is often miscoded. It has lots of potential errors. And crucially, clinical systems only capture what has happened, not what should have happened. So if you're working in your practice with a constrained workforce, the clinical system can only say, here's what we were able to achieve with that constrained workforce, not here was what the actual demand was, or here's how we should have seen that patient grouping and dealt with them in any particular way. So very challenging data set there. It has a lot of prominence and there's a lot of reason why practices will rely on it. Firstly, it's the main data set that you have. And secondly, NHS England and CQC and other organisations put a lot of prominence and weight on it because really it's one of the only data sets that exists. So because we've worked with so many practices through our improvement work, we recognise this data challenge and we've created something called the Demand and Capacity Optimization tool. The outputs from which I'm going to show you today, I'm going to give you a short snapshot of how that works, about how the Demand and Capacity Optimization tool has collected data from within practices and then reported it out to the practice in a meaningful way. And the idea I'm going to be showing you is what are those critical data points your practice is missing and how do you find that data? So back to the Demand and Capacity Optimization tool. and then before I start showing you the outcomes of it, we collect data with a practice over the course of a week. We aim to do that with every patient interaction. It's a bit of an intensive effort, but in order to get this information that you don't otherwise have, it's necessary to put that effort in. We like to use the terminology of if you have a desire to lose weight, you have to change your diet and you have to go to the gym. That's a bit of effort and a bit of work, but the outcome of that is worth it. And that's where we are with this. So the tool has been designed to be as easy to use as possible. Practices log in the morning. They will, let me just get this, get it started. So practices will log in the morning, and at that time, they will make a decision about their job role. Each individual will have a different job role. So if you're working on care navigation, or perhaps you're a clinical person, you will have a different set of questions to go through. And the idea is that we're trying to capture this information about each patient interaction. We've tried to make it as short and as quick and as easy to capture it. And the data you're going to see today is from real world practices that have captured the data, typically with thousands of patient interactions over the course of that week. So you're going to get a good feel. Now, what I'm showing you on the screen is how the tool looks, how it works. And I think it's important for you to be able to understand where this information has come from and that it is real world practice information before I start showing it to you. So just while the tool works there, you can see, so it's now completed. That was for one patient. There are various journeys that a patient could take. That was the longest journey that you might take for a patient, depending on the highest assuming they have the highest complexity. There will be other much shorter routes. Depending on the role that you do in the practice, you have different sets of questions which may be shorter as well. So once you've collected the data as a practice, the system will then automatically crunch the detail, crunch those numbers. It'll provide an automated analytics report bespoke to your practice that outlines the size, nature, and the location of opportunities for improvement. And the picture you can see on the screen is the grid. The grid goes through a lot of that information. I'll talk a bit more about that in a moment. So within the practice, we asked them to collect data from anybody that was interacting with a patient, which obviously is care navigators, your GPs, the partners, AMPs, physician associates, clinical pharmacists. And if they had a triage process, a clinical triage process in place, we would expect them also to be inputting some data into the system. So then let's look at the actual data points that your practice might be missing. I've talked now about how we've collected the data. Let's have a look at the really interesting part, which is what the outcomes are. So the first question, what we have here is, are your call handlers creating your own practice demand? You'd hope not. Do we have any data about that at the moment for practices? I would say no. And this practice started having a look at whether or not the encounters were resolved right first time. So for incoming patient encounters, how many were not resolved in that first instance? And what they found were that at least 17% of all encounters were not resolved in the first time. And you're able to start seeing where that variation exists. So if you look at the chart on the right-hand side, this is taken directly from the report. A few things to highlight for you. First is in the top right-hand corner. You can see that this data is drawn from 3,407 patient interactions over the course of that week. Below that, you can see a commentary. The aim of that commentary is that so any individual in the practice can look at this report and understand what it is they're looking at. And on the left-hand side, you can then start to see the graphs that detail the data. And that far left-hand side graph, first thing you can see is for 83% of the patients, they were completed first time, and for 17% of the patients, that encounter wasn't completed first time. As you look across to the breakdown of that information, if a patient came by phone in this practice, they got about a 25% chance of not getting the right outcome first time. And then that reduces depending on if they come by e-consult or face-to-face, with e-consult having the best outcomes for patients. Now, of course, there's going to be a bit of self-selection in that. So, it's kind of interesting information, but does it really give us enough to start changing things in the way the practice works? Probably not. So then if we start looking at the next slide, which is the same information, but displayed by those that were inputting that information. And what you can now see is some of the individuals had really large numbers of incomplete calls or non-resolved calls. So each individual here has their own code. So BYVQ in this instance has completed calls successfully for 115 patients, not for 63. So it's about a third of all the patients that they spoke to, they weren't able to resolve that patient's issue first time. Same over on this side, GRAS and T3UM, virtually, nearly 50-50 for some of these individuals in terms of their ability to resolve the patient's issue the first time. So really large variances here. Meanwhile, and I don't pull this out on these slides, but meanwhile, there are some individuals that are resolving almost everybody first time. So that's great. Those care navigators are doing exactly what you'd hope they'd be doing, but others are not. Just take a quick pause at this point and say, the idea of this pack is not about measurement for judgment. So we're not trying to say such and such is not very good at their job, or somebody else is much better at their job. This is about understanding why are these issues happening. And when we when we actually worked with that practice to understand that detail, it became very interesting. What they came to realize in this practice was that those individuals not resolving issues first time were actually not supposed to be on the phones at all. They were their back office staff who they pulled onto the phones to answer the early 8 a.m. rush and try and resolve those issues. And in this practice's mind, answering more calls meant improving patient care, better outcomes, shorter call waiting times. So theoretically, they're doing all the right things in order to help the practice, in order to better serve their patients. But actually, what this data showed was that for 50% of all the people that those the back office staff spoke to, they weren't resolving their issue because they weren't properly trained care navigators. And so really what they were doing was creating their own demand for patients to come back and back and back. And nearly 20% of all the patients being spoken to in this practice, and we've seen higher at others, having to call the practice back to try and resolve the issue they initially called about. So interesting information, not tracked anywhere else. And therefore, because it wasn't being tracked anywhere else, you can't go about making improvements. You can't understand what the challenge is, where the error is. And it's interesting to note that Wes Streeting last week in his GP contract update noted that they're going to be ending the 8 a.m. rush, which is one of several announcements that we've heard for that. This practice would have a good argument for saying we've done stuff to do that, but actually they haven't done the right stuff, and they didn't realise that they were wasting nearly £7,000 a year of salary, nearly 300 hours a year of care navigator time. And obviously, there's also compounding action when those patients have to come back and back again and back again. What about then the variation in signposting in a practice? So again, it's not information that you're going to be able to hold in your clinical system. How successfully are your care navigators signposting? Well, we often see really large variation whether or not staff can correctly signpost away from GPs. Knowing that level of variation allows you to quickly identify individuals that might be able to share best practice, but also those that may need additional training. And often, small changes in this space can make a really large impact. For this practice, a 5% increase in correctly signposting away from GPs could have created or saved them thousands of appointments each year. And here we have it. So this is the data that existed for this practice. Ability to externally signpost, no, 73% of the time. Yes, 27% of the time. Now that might be entirely appropriate based on the patients that presented on that day or that week. But what you can see in the chart in the middle is there's really large variation in some of the staff that have been able to do that. So the blue is yes. And you can see that some staff have been able to signpost loads and loads of patients, and then others haven't signposted anybody at all. So then that starts to give us the opportunity to think about, why is that the case? How do we need to consider those staff members going forwards? Do they need additional training? Was this a one-off and quite an unusual week? And can we speak to the staff to understand if that was the case? Loads of opportunity for learning. And again, this information doesn't exist. What about the quality of pre-consultation information Is that causing overruns in the practice, contributing to staff burnout, contributing to long waits for patients, reducing the number of patient appointments you may actually be able to offer? Again, we don't really hold up information for this. You may hear anecdotally from your staff and your clinicians that they're frustrated by poor patient information before the consultations, but there's no data again to provide against that. So although clinical teams often said things could be better in this practice, it was always anecdotal. Here, they reported that 40% of their consultations did not have a good pre-consultation information. So that's rated by 34% as being average, nearly 6% rated as poor. Just a 1 minute overrun for those 6% rated as poor in this practice would have been 103 hours of consultation time, or more than 1,500. Potentially more than 1,500 10-minute appointments a year. Really significant numbers. These are small changes about how the practice operates that could have a really large knock-on effect to where how your staff feel in their day-to-day work, but also the care you're actually able to provide to patients. And there's often not good reasons behind poor patient information in advance of the consultation. And then once they've seen a GP, should they have, were they the right people to see that clinician? And this is as categorized by the clinicians. You can see in this one here, there's a sample size of 722 patient consultations. And again, you can see that each clinician has their own code on the bottom. What we can see is that 3 GPs or ANPs, as it may be in this instance, have a significant number of patients that they deem to be inappropriate. 2 of them above 40%, so 44% of all the patients that AS saw over the course of this week, they deemed to be inappropriate in some way. Now, why is that? Is it around the way that care navigation operates? Is it around the way that they're categorizing their patients? Is it because those patients have been brought back for checks that they actually didn't need? Lots of different options. Really interesting information, because we're often not looking at the appropriateness of these appointments. And one of our teams recently worked across a city where they found that their patient list size hasn't changed. They're now offering about 20% more appointments than they were pre-COVID to the same list size. So there's 20% more appointments to be used, but actually they're seeing exactly the same percentage of that list size every year. And so really all it suggests is we're seeing the same patients more and more frequently. So the appropriateness of appointments is a real challenge for practices that, if we're able to start to monitor and then crack, could make a really big change to the way the practice operates. And then one of the biggest things is something called failure demand. And this might not be something that you're all familiar with on the call. So I'll just set out what we understand failure demand to be. And failure demand is really any time that the patient has to come back to the practice or interact with the practice because something hasn't happened correctly in the first instance. So it might be that a patient was told to call on Tuesday to get their test results. They call on Tuesday and actually the test results aren't available till Wednesday or Thursday. And that just drives additional activity for the practice where they're having to service that because something hasn't happened correctly the first time. So in this practice, on average, we see 10% of patients having to come back due to inefficient processes. That's 1 in 10 people. We've just done this with another practice. They've got 15%, so really, really large. And what you can start to see is within the practice failure demand, the main drivers of it for this practice were the appointment booking system, missing opportunities to help that person earlier, and then script processing. So things that we can do something about. We can manage this in advance, or start to focus in on now that we have the information about the demand it's driving. It's also a similar figure when you look outside the practice and look at the local system and how much failure demand the local system might be driving. So this is things like, in this instance, patients being discharged without adequate support packages, or requests being made by secondary care that should have been done directly by the secondary care. But, and I suspect it'll be unsurprising for everybody on the call today, A delay or wait for treatment from other forms of care is the primary issue around why patients are attending the practice that actually could have been dealt with elsewhere. Now, this is interesting information at an individual practice level. When you start to round it up to a PCN level, you get a volume of data that you can start to approach your ICB with and say, ICB, can we look to focus some improvement activity around these areas because we can see the demand it's causing for us in our practice. And typically, again, that's not something that patients or that practices are able to do currently because the information doesn't exist within your clinical systems or elsewhere. Final one, I think, is do you know how many appointments are likely to require a follow-up? So some of our practices that we're working with have seen up to 40% of appointments requiring another follow-up appointment. And of those that require at least one follow-up, about 50% of those patients are going to require a second follow-up. So about 20 to 25% of all the patients that you see are going to require at least 2 follow-ups, which is really significant. If you're able to reduce that by just 5%, that would save thousands of appointments for you. And what we know is that there'll be a large amount of variation within your practice causing some of that. Some of it will be absolutely right to have that number of follow-ups, but some of it will be around variation between your clinicians. Now, typically, identifying clinical variation is very difficult. It's also something that most practices don't like to go near, but this tool does start to look at some clinical variation so that you can identify where that might be. Now, this on the screen is showing concluding actions as categorized by each staff member. And you can see here that there are more than 1,200 different patient interactions that these clinicians have inputted on. There is a really significant variance between the clinicians in how they're dealing with their patients. Now, it might be absolutely right, or you might consider it wrong, where you have a particular individual that's a total outlier. What the information within the pack allows you to do, start a conversation with them. Now, I've already said once, and I think it's worth reiterating, the pack's not about measurement for judgment, it's about measurement for improvement. So if you have an individual that's completely out of step with everybody else in your clinical team, it's about facilitating a conversation within your practice. Say, as a practice, what's the standard that we want to set? How do we want to work for these scenarios? And you can see for this practice, 47% of all of the patients that they spoke to required some kind of additional follow-up activity, whether or not by the practice or elsewhere within the system. So what do we do and how do we do it? I'm going to go back and talk a little bit about the demand and capacity optimization tool. Once you've collected the data and you read through your pack, and the pack is obviously what I've displayed so far, the pack also provides something that's called a grid. And the grid is what you can see on the screen now. So it has different domains. There are 7 different domains across the practice. Some of those domains are clinical, some of them are administrative, and some of them are focused across both. The one you can see on the screen here is encounter handling, and you can see that there is an opportunity identified, some headlines associated with that, potential benefits of focusing on that area. But then on the far right-hand side, do these things to resolve those issues, and it becomes something of a transformation plan. So if you choose to use it in this way, practices can look through the grid, several pages long, and develop a transformation plan based on the information they found that they just won't otherwise have from anywhere else. There is a little bit of complexity detailed here as well, so you can see reducing abusive encounters. The complexity of doing that is very high. Increasing the first call rate, the first call completion rate, the complexity is deemed medium. So, summary. I've provided there 5 examples of useful data you don't have in your practice currently. We've shown across those 5 areas, of which, of course, there are many more. Collectively, and on average, practices will be wasting thousands of appointments a year because those areas are not being actively monitored and you're not able to see whether or not they're causing demand into your practice. Each one of those inappropriate or avoidable appointments has a negative effect on your patients, but also your staff. And lots of what's detailed in the demand and capacity optimization tool are areas that will be causing grit in the gears, frustration, burnout, challenge, and often staff feel that they can't really make the change that they need to make. And often that's because you don't really have the understanding or the data around what the issue or the primary cause of those things are. Of course, when you're doing those, when you have inappropriate appointments, it'll be costing you thousands in both staffing issues. So if we think back to the Care Navigator piece at the start, they were spending thousands on manning those phones and really bringing lots of demand back. Our key takeaway from today is the data's out there, the solutions are out there. You need to find them, and we'd be more than happy to help you do that using our demand and capacity optimization tool, and then use our grid to direct your improvement journey onwards. If you'd like to see more information about the tool, you can do so at the demand and capacity website, which I think you may well have. I haven't seen whether or not I have any comments. Adam, I see you've messaged here saying, would I be right in thinking that the system used is like the one used during the Accelerate programs? In Accelerate, which is now known as GPIP or Practice Level Support, User Tool for Appropriateness of Appointments. It has a similarity to that, but this is a much broader view. So there is some element there. Sarah, love that question about whether or not we offer transformation plan once you've run it. There is 2 steps really to that. The first step is for you as a practice to look through the grid and decide on the areas that you think are your biggest priority. From that, you can create a fairly reasonable transformation plan around the areas you'd like to focus on. We would then suggest that you talk to your ICB about accessing NHS England's practice level support programme. So that is a continuation from what Adam's mentioned there, which is the Accelerate programme. So Accelerate has been rebranded to practice level support. That's an NHS England based programme where facilitators come into your practice and help you make change. Now, the key part here is you need to be making the right change based on the right data, which hopefully the tool will provide you. But my recommendation strongly would be to talk to your ICB about accessing that. You are also welcome to talk to us. We provide that programme for NHS England, so we deliver that. So we'd be happy to work with you either through that tool or independently. Sarah, if you're based in Wales, that's fine. Yeah, talk to us independently. We can work with you separately on that. And Sarah, your other question there, can you run the DCUT tool again and monitor the changes? Yes. So we're very open about the pricing structure for the tool. It currently costs £3,000 per practice. You're able to use the tool as many times as you like once you've fulfilled for that. So it's a one-off cost that lasts a year. Over the course of that year, you can run the tool many times as you like. You could run it every week. Wouldn't necessarily be my suggestion to run it weekly. Typically, what we see practices do is run it every 6 months. So run it, make some change, run it again in 6 months and see where you are, and then modify your transformation plan as you've seen the new data come through based on either the improvements you've made or new things that have occurred in your practice. Brilliant. Well, I said I was going to finish at past. It is exactly past. So thank you very much to everybody that's joined. We will share a copy of the recording today. If you'd like to get any more information or visit our website, you can scan the QR code in the top corner now. And I think you'll be followed up as well with an email from today's session, just providing a copy of the recording and any contact details. Best of luck to all practices on the call. It's a really challenging time out there. We know it and you know it. So best of luck in all the challenges that you have. If you'd like to talk to us about using DCUT to start solving some of those, we'd happily do that. But if not, we hope you've been able to pick up something today as well and take it away that you might be able to use. Thank you, everybody. Have a lovely rest of your day.